Hello everyone. Today we are going to see about the bacteria Clostridium difficile. First of all, what is Clostridium difficile? Clostridium difficile causes nearly 500,000 infections and 29,000 deaths in the United States every year. Introduction. Clostridium difficile is a gram-positive bacteria, spore-forming anaerobic bacillus. Most common cause of nosocomial diarrhea. Rate and severity of CDAD, that is Clostridium difficile associated diarrhea, is increasing. New strain of Clostridium difficile with increased resistance and virulence are identified. It is a bacterium that can cause symptoms ranging from diarrhea to life-threatening inflammation of the colon. Illness from Clostridium difficile most commonly affects older adults in hospitals or in long-term care facilities and typically occurs after use of antibiotic medication. Epidemiology. It is present in the environment. Hospital is major reservoir. Spore can be recovered from surface for months. Fecal oral route transformation. Transmission occur from asymptomatic colonized persons. Colonize the colon of up to 3% of healthy adults. 15 to 25% of debilitated and antibiotic treated hospitals adults colonized. Toxigenic strains may cause disease in colonized patients, implicated in approximately 25% of cases of antibiotic associated diarrhea. The antibiotics most likely to cause diarrhea: cephalosporins such as cefixime, Ceprax and cepodosime, Vantine, clindamycin, Cleocin, erythromycin, penicillins such as amoxicillin and ampicillin, tetracyclines such as deoxycycline and minocycline. Other predisposing factors: previously experienced antibiotic associated diarrhea while taking an antibiotic medication, or age 65 or older, have had surgery on your intestinal tract, have recently stayed in hospital or nursing home, have a serious underlying illness affected your intestine such as colon cancer or inflammatory bowel diseases. Source of infection: Clostridium difficile bacteria can be found throughout the environment, in soil, air, water and human and animal feces. A number of healthy people naturally carry the bacteria in their large intestine, but Clostridium difficile is most common in hospitals and other healthcare facilities where a much high percentage of people carry the bacteria. Clostridium difficile, vegetative versus spores. Vegetative form, metabolically active, produce toxin A and B, killed by some antibiotics only. Oxygen exposure kills. Spores, not metabolically active, no toxin production, not affected by antibiotics, oxygen exposure doesn't kill. Not all Clostridium difficile strains carry genes for toxic production. Pathogenesis: disruption of normal colonic flora, colonization with Clostridium difficile, production of toxin A, positive or negative B, mucosal injury and inflammation. Microflora of gut: 10 power 12 bacteria or gram, 400 to 500 species, colonization resistance. Transmission: fecal oral route transmission by spores, late log early stationary phase, toxic production. Clinical features: mild disease, mild abdominal cramping pain, endoscopic findings of diffuse or non-specific clotids. Moderate diseases: fever, dehydration, nausea, malaise, profuse diarrhea, abdominal distension and cramping pain. Moderate leukocytosis, fecal leukocytosis. Clinical manifestations: fulmination colitis, rare, 2 to 3% of patients, especially elderly. Serious: ileus perforation, megacolon, death. high fever, chills, marked leukocytes more than 40,000. May not have diarrhea if ileus or megacolon. Risk of perforation, sigmoid colonoscopy. Treatment surgically. Unusual presentations. Long latency period for 1 to 2 months. Absence of antibiotic exposure. Severe disease. Usually profuse diarrhea, may be little or no diarrhea. Abdominal pain, fever, volume depletion, marked leukocytes, peritoneal signs. Radiologic signs include ileus, dilated colon, and edematous colonic mucosa. Endoscopic findings of adherent yellow plaques. Complications of Clostridium difficile associated disease. Pseudomembranous colitis. Toxic megacolon. Perforation of the colon, sepsis, death. Patients at increased risk of disease. Antibiotic exposure, gastrointestinal surgery or manipulation. Long length of stay in healthcare setting, infected roommate, comorbid illness, immunosuppression, advanced age, proton pump inhibitors and H2 blockers. Predictors of severe disease. Leukocytes more than 20,000, increased creatinine above the baseline. Diagnosis. Endoscopy, pseudomembranous colitis, culture, cell culture cytotoxin test, ELISA toxin test, PCR toxin gene detection. Laboratory diagnosis. Stool culture, latex agglutination to detect antigen in stools. Tissue culture assay for cytotoxicity of toxin B. Enzyme linked immunosorbent assay, ELISA, for toxin A and B. A new strain of Clostridium difficile, NAP1, toxin type 3, unsuppressed production of toxins A and B, associated with presence of binary toxin, increased resistance to clindamycin and fluoroquinolones, potential for increased complication and adverse outcome. Management. Enhanced infection control measures, targeted antibiotic restriction, appropriate antibiotic therapy, adjunctive therapy, probiotics, IVIG, toxin binders. Important supporting approaches. Surgery, avoid peristaltic and opiate drugs. Experimental therapy, rifaximin, tolivamir, corticosteroids, vaccine, monoclonal antibodies to toxins A and B, non-toxigenic C, difficile. Antibiotic therapy. Oral therapy, vancomycin, metronidazole, unable to tolerate oral therapy, IV metronidazole, vancomycin via NG tube or enema, vancomycin plus rifampin. Less frequently used, bezitracin, fluidic acid. Indications for vancomycin therapy. No response to metronidazole, metronidazole intolerance, pregnancy and child less than 10 years. Severe fulmination CDAD, Clostridium difficile associated disease. CDAD continues to be an important topic in clinical practice. Increased numbers and severity of CDAD. Active surveillance recommended. Early diagnosis and treatment are important for reducing severe outcome. Judicious use of antibiotics may reduce incidence of CDAD. Strict infection control practices essential. And finally, prevention. Hand washing can reduce incidence of Clostridium difficile infections. Thank you.